It is November the 30th, 2018, and this is episode 4 of the official podcast of the Royal New Zealand College of Urgent Care. Coming up on this episode, we talk gout with Professor Bruce Arroll. We look at trephining subungual haematomas in the nurses' station, and we recap some of the topics from this month's Urgent Bites. So welcome to episode 4 of the official podcast of the Royal New Zealand College of Urgent Care. My name is Guy Melrose and I'm your host, and this week I'm joined as ever by Dave Sorrell, who's the co-host this week. Hello, Dave.
Hello there.
You must be relieved that the exams are all over.
Exceptionally relieved.
So you're in that post-exam glow. So we'll jump straight in now with our talk. I sat down last week with Professor Bruce Arroll to talk about gout. So we will listen to that and then we'll have a chat afterwards. Okay, so I'm here with Professor Bruce Arroll, who is a professor of general practice and primary healthcare at the University of Auckland. He is also a practicing GP in Manureira, and he is the director of the Goodfellow unit, and he has a special interest in gout. And gout is something we see in urgent care quite frequently because people get acute pain and they see us as the port of entry to get their pain relief. And those sorts of people are often the ones who aren't engaging with their general practitioner. They get their pain relief from us and they end up going home happy, but then they don't necessarily engage in the preventative treatments for gout. And gout is a lifelong condition that can cause a number of problems. So because of his interest and because I've been to one of his talks before, I asked Bruce if he would like to talk to us about gout in urgent care, and he kindly said yes. So thank you very much, Bruce, for agreeing to talk to us today.
Yeah, my pleasure.
If we just start with a little discussion about what is gout and how it's diagnosed, I think it's probably a good place to start.
Well, I guess the technical name of it's a crystal deposition condition with an inflammatory component, which presents usually with pain in a unilateral joint, so one joint, and most commonly the big toe, and that's pretty easy. Probably the next is the knee or the ankle, and they're a little bit more tricky to make the diagnosis, but most of us make the diagnosis on a clinical basis. And there was a gem some time ago on making the diagnosis on a clinical basis from America. Doesn't take into account ethnicity, which sort of makes it a bit easier here. If you've got a Maori or Pacific man, then you need to be thinking of gout. So being male helps with the diagnosis. Previous episode helps. Onset within a day, joint redness, first metatarsal joint. If they've got one other cardiovascular, hypertension or cardiovascular disease, that gives you some points. And you want the serum uric acid greater than 0.36. Although that can be a little bit tricky because there is this idea that uric acid can be low during an acute attack. So if you think it's gout and you've got a uric acid of 0.34, you need to get that repeated at some time when the patient's stable, maybe a month later, as you may not be able to rely on that. I have to say my experience has been usually the uric acid is elevated, but the official guidance is to just be a bit cautious. But it's good to get a blood test in an acute situation because you can check the patient's kidneys. So that makes it easier for people, if they go back to their GP, they can then know how to target the allopurinol.
So in my experience, the typical patient that I'd be most concerned about is the young Maori Pacific Islander who uses the urgent care clinic to get their analgesics, and then they go off into the world to wait for their next attack. What are they potentially doing by not managing the chronic condition and just managing the acute things?
Well, the risk is that they're getting joint damage and tophi around the joint, which can be painful. They can end up with a very painful joint, and this can happen at quite a young age. I saw a 35-year-old Samoan man whose gout was so bad, his hand was a claw hand. I had to put my finger in this claw of his hand. He had such bad tophi. So some of these young guys can have problems, but the issue, as you raise, Guy, is getting them to start prevention. Even if they go and see their GP and they get started on allopurinol, most GPs have this experience of patients starting on allopurinol many times before they stick with it. Very hard with males under the age of 40 to get them to take a pill every day for the rest of their life, when they can just come in and get an anti-inflammatory and sort of fix it. So it does require a little bit of education. And on our website, gouthappyfeet.com, we've got a bunch of handouts in English, Tongan and Samoan. And that has a great picture on it. It has a picture of a Pacific Island-looking man with sort of like an X-ray photograph of his foot. So it looks red on the outside, but you can see the joint damage on the inside. And that's quite a good way of getting the message across. Well, this isn't just something that's happening on the outside of your joint. This is going on under the hood, if you like, and you could be getting damage. But I'd have to say, don't hold your breath in men under 40.
And one of the other reasons in urgent care we might have not addressed that chronic side of things in the past is that there's been a belief that starting allopurinol is not good in an acute attack. You're reasonably confident that that's not correct, is that right?
We did a randomised trial of this, and we thought we were going to be first in the world, but in the meantime there are a couple of other papers which did it, showing that it doesn't matter about starting allopurinol. However, the key thing is to get the patient to have a behaviour change and start taking a medicine every day to deal with their gout. And we use the blister packs, which have, if they're not diabetic, they have prednisone in them, and colchicine to prevent flares. And the allopurinol kicks in after 2 weeks. That just keeps everybody happy. Some rheumatologists are very twitchy still about, in spite of the evidence, about starting allopurinol. And it sort of doesn't matter. It's a long race. It's a long, this is a lifetime thing, so there's no great hurry. And if you use a blister pack, and we have the prescriptions, recipes, if you like, your local pharmacy, if you have a good relationship with the pharmacy, you just say, I want, depending on the uric acid, option 1, gout pack. Patient goes down and gets it. So you can actually do the acute treatment and the prevention in under 7 minutes. I give a talk on that, treating gout in 7 minutes, which is going to be important in the urgent care setting. You've got people lined up, and you can't spend 15 minutes. And people actually aren't that interested in education when they've got acute gout. It's not the right time to. At one point, it is the best time to do education, but actually they just want pain relief, and you're probably talking to the deaf while they've got the pain.
So you mentioned the uric acid level. We might do bloods to rule out maybe infection. We might do bloods to check renal function, but we might not get those results for a wee while. But there is the finger prick test. Is that, in your experience, suitable for determining which one of these two regimes to commence? It'll
only tell you the uric acid. It won't tell you the creatinine. It's the creatinine that guides the option. So option 1 is an EGFR of greater than 60. Option 2 is 30 to 60, and option 3 is 10 to 30. But it's recommended if somebody's got an EGFR of 10 to 30 that you may want to discuss that with a rheumatologist, but that may not be possible after hours or on a weekend. So it's the creatinine really that you want to get at that point, the uric acid. The finger prick's more useful for people when they come in and are they still taking their allopurinol. And I have to say often they're not. They say they are, and you do a uric acid and it's 0.54. And then you say, well, have you forgotten a pill? And they say, oh yeah, I did forget a few, and was it more than a few? And was that over a period of weeks? And you get the truth will come out. So getting people to take, particularly young men to take medication is a tough one.
And that obviously falls very much in the sphere of general practice, but what we're, I guess, getting at here is trying to catch those guys who aren't engaging with GPs, but we're recognising they're coming through us regularly with repeat episodes of acute gout. How would you... Is it a case of like using that photo to scare them into what could happen, or is it in your 7-minute talk? How do you find you best engage them to take it seriously?
Well, I'd be talking about them going on to preventive medication if I'm going to give them the blister pack, and I would print out the I go to the website, print out the handout, and I always show them that picture. I just say this is what's going on inside, and it's all that issue of behaviour change with patients. You know, we all have our own nice little ways. I call them killer narratives of explaining to somebody what you need to do, and you might want to scare them, particularly if they're having more than 2 attacks a year regularly. They are at risk, and they may not have any damage yet, but it may be happening. So I think that's going to be up to the individual, clinician, how they do that behaviour change. The key behaviour you want them is willing to take a pill every day, and of course with a blister pack they're taking a whole bunch of pills to start with when they're starting allopurinol, but just getting that behaviour change of taking a pill every day. And I sort of don't worry too much about getting them to target. Nice to get them to target. The key thing is to get them to take a pill, allopurinol, every day to prevent their gout. And then you worry about the uric acid levels afterwards. But the target is 0.36. If you get below, even if you get below about 0.4, it's very unlikely somebody will get a gout attack. So you'd worry that they're not taking the medication if they're getting gout attacks. Or I guess the other thing is they may not have gout. So if they've got a low uric acid and they're still getting gout attacks, like below 0.36, then you have to reconsider the diagnosis. It may be an arthritis. The other point I was just going to make, I think the other thing is just the vital signs, is measuring the temperature in all these people. And I think you do that in the urgent care clinics routinely. We had a patient in our trial whose temperature was 37.1, and that was a rule out. And he actually had an osteomyelitis of his toe, so that was a bit of a horror show. So any temperature over 37, I would certainly not give prednisone. You might want to give anti-inflammatories or colchicine. Just because a septic arthritis is a disaster. That's always the tricky one in those acute settings.
With regards to diet, the old-fashioned Henry VIII diet of red meat and wine, etc., is that still a no-no for patients? Are we because a lot of guys, particularly Pacific Islanders, enjoy their seafood and they don't like to be told necessarily that they have to restrict that. So is the treatment, does that enable them to carry on their normal diet, or is it still worth mentioning diet?
No, I think that's actually, it's very hard to reduce your gout attacks by diet, and our group at Counties has actually given up that. We just go for medication, basically, because it's very hard to keep your uric acid down by diet things, particularly as you're getting older and your kidneys are starting to get less effective. So we tend to, and one of my selling points is you can eat seafood if you take the allopurinol and have the occasional drink, because a lot of these Pacific guys give up the seafood, which probably isn't a good thing for their general health. The other thing is just the issue of if you have time, is to check the blood pressure and do a CVD assessment is the other thing, because these people are at high risk, and they'll generally be over the age of 35, which is now the age for Maori and Pacific men to do their CVD risk. I mean, that's a lot to do in an urgent care consultation, but it's something to be cognizant of. Sometimes their blood pressure will be quite high because they're in pain. Of course, that's not necessarily, but one of the blood tests could be a lipids and an HbA1c, just to be complete on that.
The GPs are obviously the ongoing management. As a GP, would you should be getting letters from urgent care clinics when people have presented. Mm-hmm. So do you follow those up in terms of regularly sending out appointments to see these patients?
Certainly. Well, in our clinic, the gout management is nurse-led. So if I got a letter from urgent care thing, I would ask the nurse to contact the patient, and they're probably known to us for gout anyway. It would be unlikely that somebody would turn up, although that of course would happen from time to time, and then see if they'd be willing to come in. We do this thing called the the GP bypass study where the nurse phones the patient and gets them to go to the pharmacy, and the local pharmacies up-titrate the patients so they don't have to go to the lab, so long as they've got a creatinine sometime this century, basically. And they do the up-titrating there. So it gets the patient out of having to go to see us, to see the lab and see the pharmacy. These aren't people who want to spend all that time with healthcare services. Often guys in manual jobs, trouble getting time off work to come in, which is why they come in for the acute thing. They have to come in for that. But to do the other stuff is actually quite hard. So there's a lot of system barriers for particularly Maori and Pacific men.
So you would recommend we go to gouthappyfeet.com.
Yep.
And all that information is there, including your talk on the 7-minute gout.
Yep.
Consultation and all the pharmacy blister pack information.
Yep.
So working closely with the pharmacy next door would be the first place probably
Yep.
to start to get
Yep.
them on board. And you've just mentioned that they monitor. Is
Yeah,
that through
so
the finger prick?
Yeah, they
test
have
as well?
well, some pharmacies do, not
Yeah.
all. So you'd have to, might be something they'd be interested in, because our pharmacists really enjoy, and they get extra money from the DHB.
I was going to say, is that a funded thing?
Yeah, it is. It is in counties, but I think it's one of those things you have to start advocating for in your own area. So well, they're doing it in counties. Why can't we do it here? And patients really like that. So because it's just one, it's 2 steps less to go. You still got to get that first creatinine, of course, but I think it's getting that behaviour change is the key thing, and the creatinine can always be done later. I think if you started them on 100 milligrams of allopurinol and their uric acid went from 0.54 to 0.1, you'd wonder what the status of their kidneys was, and you'd definitely want to know, were they in sort of early renal failure or something. But for most of them, their kidneys are going to be fine. You'll probably have a creatinine somewhere in the system. I don't know how easy it is for you guys to access that, but if you are going to take bloods, then uric acid, creatinine, lipids, HbA1c would be the bare minimum in those situations. White count if you're worried about infection.
And is there anything coming in the future for gout management? Because there's the adenuric drug that was being pushed a couple of years back, but you're still talking about allopurinol. So it's still
for buxostat, an option if you fail on allopurinol, and that's so rare. You have to fail on 600 milligrams of allopurinol. Just about everybody gets to target on 600 milligrams. It is very easy to use the febuxostat, and there may be the odd patient willing to pay for it. And it's often just one tablet. You don't even the up-titrate. The first tablet often takes you below the 0.36. So sometimes it's a little bit easier. You still have the risk of flares, so you still need a bit of colchicine to start with.
And you like the colchicine do you have many patients not tolerate that? Is it something?
In the low dose, it's fine. Basically, the old days of increasing the dose to the patients got diarrhea actually killed people with liver failure. So I never go above 3 colchicine a day. I give 1 to 2 the 0.6 microgram doses daily to prevent flares for 3 to 6 months. Some of the rheumatologists say 12 months. But it's all that pill load stuff, and I think if you just warn patients they might get a flare, that sometimes starting allopurinol may trigger off a flare. Ironically, actually, twice a day is actually more effective than 3 times a day with fewer side effects. So it's one of the few situations where lower dose is better than higher dose.
So one thing we're going to see in urgent care is the patient who comes in hobbling or on crutches in significant pain, and that's the primary driver to obviously come to us. So how do you address that initial acute pain?
Well, there's 3 options basically. If they're not diabetic, then you can give prednisone 40 milligrams. We give it for 4 days or so, and then gradually decrease it in the blister packs. Again, you've got to be sure they haven't got septic arthritis. The alternative is non-steroidals, but there's been a recent trial showing that there are more side effects with non-steroidals than there are with prednisone, and I guess you have to be comfortable using prednisone. And I'm sure most of your guys, once they've had a few years under their belt will be pretty confident with it. Some GPs get a bit twitchy about giving prednisone in acute attacks. And if you're, as I say, if you're unsure about whether it's a septic arthritis, then you might want to give a colchicine or non-steroidals and watch them with CRPs and white counts and things. And that'd be somebody you'd probably want coming back to see you, because you don't want that person going off into the back blocks.
That's one problem with people coming to us. They might be working in the area and come to one urgent care clinic, then they might go to another, and they might build up a series of prednisone scripts. Do you have a limit in an annual period of how many times you would let one of your patients have prednisone?
Well, I certainly wouldn't want them taking it every month. I don't think I have a rule around that. But I think the other thing is, and I had a gem on this a while ago about the risks of short courses of prednisone, and I have some personal bad experience with this. When I was on 40 milligrams of prednisone for a wheezy chest, I had a complete fracture dislocation of my ankle on Mount Eden, not on a very dangerous part of the world. So I was delighted to see the article pointing out there's a risk of fracture. Numbers needed to harm about 800, so it's pretty rare. Increase in venous thrombosis and increase in sepsis. And this was in a young population. This was people under 65, so it wasn't looking at older people. So you have to be a little bit careful with those things. But of course, NSAIDs have problems, and colchicine has problems. You know, there's no
So
easy
your preferred
magic
NSAID would be?
well, we recommend Naproxen 500 BD in the blister pack. I don't think it matters. Nurofen, ibuprofen, Voltaren. I don't know quite how it works with these. You may have a better feel for the longer acting Voltarens. I think people often need a bit of like 50 milligrams TDS to start with. That's what I used to use in the old days. I don't know quite what to do with these longer acting Voltarens, quite how quickly you get a blood level on them. But I tend to use prednisone all the time, basically, unless they've got diabetes, and then you have to sort of think about it. If they're not badly diabetic, I think they could tolerate. But if they're using insulin, then I wouldn't use prednisone. I've put a few people in hospital giving prednisone to people, not with gout, but who are taking insulin for their diabetes. So you can really mess somebody up.
And the other differentials of pseudo-gout management in the acute setting is the same, obviously.
Yep.
When do you start to think of that as a diagnosis? Because it would be an aspirate that would diagnose that, would it? Or is it?
It's usually a radiological diagnosis,
Right,
I think. You know, I tend to pick it up because somebody has a knee X-ray and comes back saying they've got pseudo-gout. It's pretty rare in my experience compared to... So the things would not be adding up. The patient would have a normal uric acid. I don't think you can do an aspirate, but that's something I'm not 100% sure about. But it's much, you know, compared to gout in New Zealand, at least, it's way less common.
But an aspirate in general for gout is not required in your feelings if it looks like gout, particularly of the great toe.
And people like Peter Gow, the very experienced gout rheumatologist, doesn't do them anymore. So it's possibly a lost skill, but it's not absolutely essential, I think. If you've got most of the criteria and it's a Maori and Pacific man, then you've probably got gout. And the other thing is they'll probably have a family history too. That can be quite helpful. I see these Maori men and they haven't got gout and nobody in their family's got gout. And then you've got another one who's got gout and everyone in the family's got gout. So it does, you know, make you think of a genetic cause there. So gouthappyfeet.com has everything there. And if do you have any talks coming up on gout in the future? No, we have a podcast on the Goodfellow Clinics podcast, and that goes through basically about acute treatment and getting chronic treatment.
Yeah, it's worth mentioning Goodfellow is a great resource for there's online learning resources there and podcasts, and there's the Goodfellow Symposium every year, which is a great opportunity to learn things. So if you go to it's goodfellowunit.org and there's lots of information there too. So hopefully we can manage acute gout successfully, as I think we have been over the years, but also start the process of catching some of these people who would otherwise be teeing themselves up for a future of problems that were otherwise very preventable.
Yes.
If we follow your advice on gouthappyfeet.com, and also check out some of the teaching material on the Goodfellow unit as well. Professor Arroll, thank you very much for your wisdom and teachings today. It's much appreciated.
My pleasure.
Okay, so that was Professor Bruce Arroll talking about gout, something he knows a lot about. Dave, what were your thoughts initially from an urgent care point of view?
So obviously Bruce knows at least 10 times more about gout than I do. And my approach is based on a different approach. First of all, is not doing harm to the patient. So is it actually gout or is it septic arthritis? That's always got to be the most important question. And sometimes that decision is very easy and sometimes it's not. So when you have someone who comes in with a typical, especially second episode of small joint inflammation, such as the big toe, I think it's usually fairly obvious. However, in other circumstances like hot wrists, hot elbows, and hot knees, you have to think very seriously as to whether you need to exclude septic arthritis, and that's your most paramount decision. And if that's what needs to be done, then they need to be in hospital so that the joint can be aspirated and have immediate microbial examination and microscope analysis. And that should always be done, in my opinion, in the hospital, because there's no way you can do it in a speedy fashion in the community. Once septic arthritis has been excluded, then you consider the treatments. And as with a lot of urgent care doctors, I think colchicine is probably third line for me because of the risks associated with treatment. But regardless, you need to know the renal function for cases that you're going to give colchicine or non-steroidals to. And sometimes that's a bit of a challenge. And so sometimes you have to see if you can access previous lab results or order some urgent blood tests. I agree that prednisone is a good drug to use when there's no signs of infection. And I agree that infection can be hard to exclude sometimes. So a lot of the time you're going to have to make an assumption, but make sure it's a safe assumption, and treat with prednisone. The doses reducing that Bruce has suggested is perfectly reasonable. I don't really have access to blister packs, so I have to do a prescription that's easiest for my patients. I do use anti-inflammatories quite a lot, but obviously very, very careful with anyone with ACE inhibitors and diuretics. That's a big no-no. You don't want to triple whammy your patient who comes in with gout. And so be very mindful of the contraindications to the medications that you use. And obviously some patients will need some regular doctor to consider urate lowering medication. Personally, I don't usually do that, but I can see where Bruce is coming from with the patients who do need that follow-up. I'm always encouraging them to see their GPs. And sometimes it's important to give good advice on discharge for follow-up. And blood tests, quite commonly I'll do a full blood count, a CRP, and renal function with the ones that I'm not 100% sure, or anyone that I'm using an anti-inflammatory and they haven't had renal function done in a year.
Yeah, it's that ongoing care is the problem, because urgent care is not about that. It's about getting them back to their GP. But a lot of these guys don't have a GP, or they circle the no notes to GP box, and they just want to be pain-free and then carry on their life. So finding a way to maybe instill in them the significance of this problem going forwards in their life is, I guess, one thing I took from this, to use some of the handouts that are available on gouthappyfeet.com to show people that they are potentially setting themselves up for problems later in life, and then they may only be in their mid-20s, but it's still our job as physicians to address that, particularly if we recognise that they're using us as a default GP service rather than seeing their GP. So I guess trying to nudge them back to their GP is important, isn't it? And in all urgent care problems, but not.
And like you say, give them information to take with them and tell them to take that to their doctor to consider gout urate lowering medication. And if you've done that and then you see them again, well, maybe that's the time where you say, well, you talked about this last time. Can we consider starting this medication? But yeah, strongly advising them to get a regular GP and to have follow-up is an important role.
I think Bruce mentions that even as a GP, he starts young men on allopurinol and they stop, and then he starts and stops, so that it's more of a long-term war rather than a short-term battle. But I guess it's one of those areas where urgent care and general practice has a little bit of crossover in that regard. So anything further to add on?
I think it's worth mentioning the ultra-low colchicine dose. So as I say, colchicine's third line for me. If you do know the renal function, or even if you don't know the renal function and they haven't had any recent colchicine, there is an ultra-low dose colchicine, which is in the New Zealand formulary, which is 1 milligram of colchicine stat, then 500 micrograms of colchicine 1 hour later, and that is the complete course. So they only have 3 tablets for their entire course. It's recommended that it's started within 24 hours of the acute episode of gout, and it is, in a lot of papers, it's reported to have a similar side effect profile to placebo, with similar efficacy to the low dose and the regular dose of colchicine. And I note that it's in the Australian prescriber and the Australian family physician that they use this and do recommend it. But it's not strongly recommended throughout New Zealand. When I use colchicine, that's the dose I use because I think it's got the least chance of killing my patients.
That's obviously not the desired outcome, but you have it as third line. It's not really in your commonly used arsenal.
Yeah, so if a patient's had colchicine before and has got a known renal function and they're well and it works for them, that's the dose that I actually recommend because I'm kind of comfortable with it. But I know that other doctors use other doses. So it's when you look at the low dose, the only patients that won't be okay for is the ones with a renal function less than 10 mils per minute. It'll work for the other ones. It will be within the safe range because it's still going to be less than the maximum dose. Although I guess technically for the very low renal function, it's more in the first 24 hours, but it's going to be less than the 3 milligram minimum for the poor renal function patients. But of course, if they got ultra low renal function, then you shouldn't be using it at all because it's too dangerous.
Right, so that was gout. As we mentioned in the talk, if you go to the Goodfellow Unit website, you can find some more information there, both from Bruce and some other rheumatologists, and gouthappyfeet.com. And that's gout. So if we move to the nurses' station, this week we have discussed trephining of nails. So we'll pop over there and discuss that in a minute. Okay, so welcome to the nurses' station. I'm here again with Amor Kisling, nurse practitioner in urgent care. Thanks for joining us, Amor.
Thank you for having me again.
So today we're going to talk about nail trephining, which is a very common procedure in urgent care, and it's something that is relevant to both the doctors and the nurses, which is again why we chose it today. So if we start at the beginning, when do we need to trephine a nail? What is the sort of indications for a nail trephining of a subungual hematoma?
So firstly, a subungual hematoma, it's caused by blunt or sharp trauma to the fingers, and bleeding just causes increased pressure under the nail, and that can cause significant discomfort. So it's indicated in the presence of a painful subungual hematoma with the nail edges that are intact, also again with the presence of trauma. The size of it is debatable according to research, but it justifies trephining if it's painful. Currently,
Sorry, I was going just going to say, some people say over 20%, 10, 20%, up to 50%. It is variable, but generally the bigger they are, the more painful they're going to be. So a small subungual hematoma that isn't painful, like you say, doesn't need to be trephined, because if it's not painful, the only reason to trefine them is to ease that pressure.
Yeah, and it's also recommended to trefine subungual hematomas present less than 48 hours, because if it gets over that, it gets all clotted and it's really not worth it. And before you do that, it's also just important to make sure to check for extensive tendon injuries and underlying fractures or nail bed injuries.
Yeah, it is important, as you say, there's got to be trauma here. So if somebody comes in with a subungual hematoma or discoloured nail without the history of trauma, then you've got to be thinking, obviously, of other things. So there needs to have been some trauma, and an X-ray to exclude fracture is obviously very important. And as you say, if they've come in 48 hours or more after the injury, then it should have become really painful by then. I've never personally had one, but people who have find it very hard to sleep. The throbbing is very distracting. So most people with a subungual hematoma that needs trephining usually have made their way into an urgent care clinic within that 48-hour time. What would be the contraindications then? When should we not be thinking of it as a simple treatment?
So if there's a suspicion of nail bed injury, the nail will need to be removed for nail bed repair. In some situations, patients might have better cosmetic outcomes with nail removal and nail bed repair. If there's no pain, then trephining is not needed. If you have patients with acrylic nails, that needs to be removed because they have the potential to be flammable.
And just for the uninitiated amongst us, an acrylic nail is a false nail.
Yes.
Yeah, that's stuck onto the a
onto
normal
the nail bed.
So
yes,
there should be a
nail
normal
bed.
nail underneath there.
Yes.
Somewhere. Do you have any
But
idea
it's
how
hot.
you remove them? Do you need a solvent of some kind?
It needs to be soaked in acetone. Yeah.
Okay. Very good. So keep an eye out for an acrylic nail. But yeah, they apparently don't like to be heated up and melted because they're quite flammable. Apparently, is that right?
Yeah. Yes.
Yeah. So
Correct.
the significant underlying nail bed lacerations obviously need to be repaired, and when you've taken the nail off, you've then you've gone way beyond the needing for trephining. So trephining really should be in the presence of a simple, traumatic, painful subungual hematoma. So when you've decided that it's time to go and get this blood released, what methods are there available to do this?
So recommended electrocautery tool or 18-gauge needle. So the electrocautery tool is preferred. It is a bit more expensive, but it's quicker, easier, and less painful.
Yeah, so that's like a battery-powered pen that's got a loop of wire at the end that gets red hot when you press a button. And the advantage of this is it maintains that red hot temperature as it goes through the nail. You mentioned the needle there as an alternative. Some people do find the cautery a bit warm and pain and adds to the pain, and there are some advocates for using the needle as a drill to sort of slowly and gently drill through the nail, which is certainly an option, but you've got to make sure that the hole it creates is big enough to then allow the blood out at the end of it. So certainly the preferred technique is one of those electrocautery tools because it leaves a nice big hole. Under the similar principle, though, there is also the old technique of heating a paperclip, but there are potentially some issues alongside those that people have reported. They include that it goes cool as soon as you stop heating it and take it over to the patient. It's obviously going to lose some of its temperature, so it might not get all the way through and require you to be pressing harder. And then that's one of the problems with trephining is if you go through the nail too far, you then damage the nail bed. So I guess the paperclip is an option, but it's certainly not the preferred one.
Yeah, I guess it's an option if there's nothing else available. But another thing with the needle, if you use it as a little drill from side to side, that can cause a bit of downward pressure as well on the nail bed, which could be a bit more painful, and it's obviously takes a bit longer than the cautery pen. So
Yeah, when we go on to pain, then there are some advocates that would say anaesthetic is helpful, so a ring block might be needed. Generally, that's not felt to be the case, is it?
no.
Yeah. So, but if somebody's in a lot of pain, then maybe you have to be thinking of other things, or the quicker you get in and release that pain, then release the pressure rather, than the pain will ease. With both the cautery and the paperclip type techniques, you can get a little bit of soot build up afterwards, which needs to be cleaned out, doesn't it?
Yes, definitely.
And it's worth mentioning to the patient that there is an odour that is released by burning nail, which some people might not like, but it's worth just mentioning to them that they will smell some burning. So once you've released the pressure, it's usually quite if it's under a lot of pressure, it's a very sudden release, and it's quite impressive how far the blood can actually kind of squirt across the bed there. So it's usually a good idea to have some kind of protection on. Obviously, certainly gloves, but even face shield if you're getting your face close to this. You don't want to get blood in the face. And what do you then do afterwards once the hole's in and the blood is draining? What's
So then once you've cleaned out the debris in the hole, then you can apply slight pressure onto the nail to basically milk a little bit of the blood out to release the pressure. And then after that, it would be cleaning, dressing, and then the aftercare advice for the patient.
It's sometimes one hole is enough, but occasionally you might do more.
Need to do more, yeah.
And we mentioned before doing an X-ray. So if there is a fracture underlying it, simple tuft fractures, simple distal phalanx fractures will obviously then need to be managed also. But what's the feeling on antibiotics afterwards?
Well, there's good evidence showing that antibiotics is not needed with fractures, with simple fractures. So yeah, prophylactic antibiotics is not needed with a simple fracture. If they do, however, go on to have nail bed repair and surgery with from specialists, then they will probably need to rethink that. But
yeah, so there's we'll link to a few articles in the show notes that reference this, but there's certainly a general feeling that prophylactic antibiotics are not needed. You're not creating an open fracture in this sort of setting, and then once you've done this, what do you tell the patient about the nail? Is it?
Yeah, so just tell them that blood may continue to ooze from the hole for the next 1 to 2 days. They need to keep an eye out for signs of infection, which is warmth, redness, increasing swelling if they start developing fevers. And they just need to keep an eye on it, keep it clean and dry. And the most important part is infection. And if there was any underlying fractures, that they just need to be followed up by hand therapy and have a splint.
Cool. And they probably will lose the nail if it's had a decent...
most likely advise them that they most likely will lose the nail. So then, if they don't, they're happy that they haven't.
Yes.
But it's quite common, especially if it's a big hematoma. The chances are pretty good for them losing it.
So essentially, it's a fairly simple but very satisfying thing to do. It's appropriate for nurses to do it as well as doctors in the sort of the limitations that we described there. So more complex injuries, you've got to be thinking of other things and other managements. But if someone's hit their finger with a hammer and it's got a throbbing, painful subungual hematoma, releasing that pressure, they feel so much better, and it's a very satisfying thing to do. I think we've covered everything there. Anything else you can think of?
No, not at the moment.
Great. So thanks again for joining us, Amor, and we'll likely see you again next month.
Thank you.
Okay, so trephining nails. Dave, first of all, what's your preferred way of trephining a nail?
So I use an electrocautery pen, or the portable trephine pen, as they're sometimes called, because I have access to it. I've used every technique that's probably known to trefine nails, and interestingly, in the emergency department, all we had was a Bunsen burner and a paperclip, which was not ideal. And I have done it at school camp using a candle, a paperclip, a tissue on a 9-year-old autistic boy, which was certainly challenging, but we did manage to trefine it. I've used needles. I find the needles in New Zealand are very interesting, and it's hard to find the right diameter and length of the sharp bit. So you tend to have the 18 gauges, which are far too long and extremely painful if they go into the nail bed. The 20s, which are a little bit small. So I like using the pen, and I always have a 20 gauge needle available next to them, because often when you trefine using the pen, it will melt or sootify, and so the blood doesn't drain. And then you quickly grab your needle and give a couple of quick twirls, and it will almost always make it bleed thoroughly through. So I use the pen. Points to remember: small subungual hematomas that are not painful don't need to be trephined. I guess less than 20% or so, or less than 10%. If the nail bed is dislocated, or the nail is dislocated from this nail fold, then you're not usually going to trefine, although you do need to make a hole in the nail. If there is a badly displaced fracture, or especially a fracture of a shaft of the distal phalanx that's kind of vertical, then the plastic surgeons would still say you should remove the nail and repair the nail bed, which is exceptionally challenging. But almost always I would just trefine large to small subungual hematomas. I would always do an x-ray. I would not usually use antibiotics unless there are other reasons for it. So a tuft fracture is not a contraindication as long as it's minimal and it doesn't require antibiotics.
So you've used all the techniques, and they're all valid. It's whatever works, I guess, but you prefer the electrocautery one. What do you tell the patients to do afterwards? What's the next day? Are they meant to be soaking it? And
so I have an advice sheet with diagrams on what a subungual hematoma is. They should soak their finger for a few minutes in clean water. So normal town supply tap water is okay. You can have a little bit of soap in it, but it's not required. I just say soak it so that it stays nice and clean, and then recover it. If they're pretty active and they've put a Band-Aid on after the dressing, they should change it probably twice a day is my advice. And if they're worried that it's swelling and more painful, they should come back. Sometimes I get people back the next day just to see how it's doing, but you've got to watch for that sort of recollection phenomenon, and also look out for infection, which has not been caused by the trefine, it just occurs.
But you're happy that it isn't an open fracture when you've got a tuft fracture and then you've trephined. It's not technically...
So obviously it depends what the fracture looks like. So that if you've got a really badly displaced shaft of the distal phalanx or interarticular fracture, then it should be managed by plastics. But it's just uncomplicated minor tuft fracture, then that's not an open fracture. Although sometimes it is good to put a mallet splint on in a few days' time, because it's going to be very sore. And I also advise them the nail's always going to fall off.
Always, you just put that blanket.
If you expect it to fall off and it doesn't fall off, you're going to be happily surprised.
Yeah, fair enough. And do you always just do the one hole?
Oh, no. So you've got to... so for the thumbs and the big toes, I always put 2 in. And for the rest of them, I put 1 hole in, or I sort of assess what it's looking like. And then I get them to put their... I trefine it and I say, can you put your finger in this saline solution, because we still use saline solution, and I ask them to milk the blood out, and then I have a look. If there's a significant amount of blood still subungally, then I put in a second one. But when you look at the size of the digit, you make a call as to, do you reckon 1's going to do? Thumb's always 2, so I kind of go to the right or the left of the midline and put 2 holes in, because I find they don't almost ever drain with 1, and especially big toes. you usually have to put 2 in. And when I'm reimplanting a nail, I always put a couple of holes in, but that you can just do with a nice 18 gauge needle because it's not actually attached.
And are you routinely using ring blocks prior to trephining a nail, or?
I never use a ring block when I'm trephining a nail. I
read an article that suggested you do it, but then I've always found it's such a relief when you have done it that the pain relief afterwards is the point of doing the procedure.
I think it's not quite like draining a filon. So if you're draining a filon, it's a bit torturous if you don't put a block in. If you really want to, laughing gas can be used because it makes your patient quite at ease instead of a block, because it's an instantaneous relief. You know, I tell them, you're going to feel so much better once I do this. There might be a little sting and then you get relief. And having had it done to my own hand, it was instantaneous relief. Interestingly enough, I couldn't perform it on my own right hand. I had to get my wife to do it.
And I think that's the advantage of the electrocautery as well, because it's hot all the way through. When you use the Bunsen burner or cigarette lighter, it gets red hot, but then it rapidly cools, and you can get halfway through before it then stops.
You get stuck.
And that causes more pain. And then there's also worth noting the smell. Some people don't seem to enjoy the smell of burning nail, but
yes, it's a bit like
too late after
that line for Apocalypse Now. But it is a rather interesting smell.
You mentioned the difficulty of repairing nail beds. Is that something you still do? Or do you? Let's say it's got that underlying fracture. Is that something you feel is a plastics job?
Nail bed repairs using sutures is like suturing wet tissue paper. There is good evidence that tissue adhesives can be used to repair nail beds, and that puts you in a little bit of a quandary because there are 2 different isomers of the cyanoacrylates, N-butyl and the other one, its name escapes me. Technically, they're called Dermabond and Histoacryl. And Dermabond is always available in the hospital, and it has a couple of extra qualities, such as waterproofness, and it is applied like a highlighter over the area. Typical histoacryl is not very waterproof and crystallizes, so it is a little bit more challenging, and you have to have a very dry wound to do it. The new product, Histoacryl Flexible, is perfectly suited to this, but not everyone has access to it. It will be available increasingly in Auckland and the rest of New Zealand, and I know Amtech can source it because they're sourcing it for me right now. Histoacryl Flexible is the newer product, which has the added advantages of being between 10 and 70 times more strong than histoacryl in tensile strength, and also waterproof with the antibacterial activity similar to Dermabond. And if you have a simple nail bed laceration and you have a bloodless field, you can repair the laceration with the cyanoacrylate and then reimplant the nail, which should have holes in it once it's dried, and use the glue around the edges of the nail fold.
We might do a bit on that in greater depth at a later date, but I had heard about this glue taking over because that wet tissue paper is the best analogy, isn't it, for trying to stitch a nail bed, and it's I've not had a lot of joy with it. So that's nail trephining. I was wondering if we could just have a brief recap on some of the bites that have gone up this week, this month. Sorry, we talked about vestibular rehab, and you had some comments around that in relation to concussion. What were your thoughts around vestibular?
So I think vestibular rehab is very important, and I always use a neurophysiotherapist, is what they call themselves, for that, because I just don't think I'm quite good enough or have enough time to do it myself. Dizziness following concussion is extremely complex, and I was talking to one of the rehabilitation medical specialists from ABI yesterday about it, and we were talking about the different types. The benign paroxysmal vertigo caused by concussion is a very common cause, and it's a lot easier to treat. But you can get direct labyrinthine concussion. You can get autonomic dysfunction causing dizziness, which is usually when they stand up, and other things. So it's great to have someone who specializes in that field, who has the time, because it's a time-consuming thing, and in reality, you've got so many things to talk about with your concussed patient, and just to go through dizziness, it takes so long. And if it's through a concussion service, it's always funded, so you know that they're getting paid for it, and the patient's getting someone who's got an expert at those manoeuvres for treating the various types of vertigo.
Yeah, I thought it was interesting that there's obviously the vestibular component, the crystals that get moved around, but then there's the neck proprioception you talked about. There's the visual kind of retraining, the ocular motor kind of retraining. So all of that as a package seems to be the thing that it's beyond what we can do in our context. So
you've got to be good at doing all these things. So it's good to have someone who's an expert. It's hard to be good at everything, and so to go through each thing would probably take you an hour or two every time you see a concussed patient. So these resources are available once the ACC 883 provider referral has gone through, and you've got a provider, they can tee up the right people to do that. And there's always new things that I'm hearing about and learning about for rehabilitation, and things like noise reducing earplugs for that phonophobia are becoming increasingly funded and very difficult for us to access, but the services seem to be able to get those organised. And even specialised glasses for removing the light frequencies that cause photophobia, another step forward that's gradually getting implemented. And so vestibular rehab and VOR, which is vestibular ocular rehab, are both very important parts of the rehab of the concussed patient.
Great. So hopefully we're all a bit more aware of that. We also looked at the Cunningham technique for reducing shoulders. I don't know if you've tried that before, as a fairly gentle single operator technique. I put that on as a bite because it is a single operator, and those videos that you see of them being done, it is incredibly atraumatic and very magical. And if you're in a smaller clinic, it might be a better option for you. I've personally not had any luck with it in terms of it working, but I have occasionally used it as the first go. What's your preferred relocation of a shoulder in an urgent care setting?
So getting good at an atraumatic shoulder reduction technique is vital. I have never been successful with the Cunningham technique. However, I have been researching the Soon technique, which is a variant of the Cunningham according to some authors. And it is very, very similar in that it involves getting the patient's hand across the contralateral, although technically it's the ipsilateral shoulder. So their right hand, if affected, goes on the right shoulder of the examiner. And then they massage the deltoid and the anterior shoulder and extend the elbow, and it pops in with gentle traction. So if you look that one up, you'll see that. Personally, I use the Fares technique, which stands for Dr. Fares and fast, accurate, reliable, easy, and safe. He had to work on that one quite well. And it involves simply holding the patient's hand with the elbow extended, and then shaking the hand up and down, 10 centimetre sort of isolations about once a second, and then slowly abducting the elbow, the shoulder with it at elbow fully extended, and then externally rotated once you reach 90 degrees. And that is an extremely effective technique. Watch some videos on that if you like. I usually find that I can get 80% of shoulders back in 37 seconds using that technique. I usually use a little bit of laughing gas.
I was going to say, do you ever need? Do you ever use conscious sedation in this setting?
Conscious sedation is challenging and dangerous. And so there is a minimum requirement for doing any form of conscious sedation. You've got to remember that as soon as the shoulder is reduced, the pain is removed and the patient may well stop breathing. Internox alone doesn't count as conscious sedation. It's when you start mixing your drugs. So the Australia and New Zealand, the ANZCA, has described what conscious sedation is and how it can safely be performed, and their guidelines must be followed in all circumstances. My advice outside of the hospital setting is to find an atraumatic technique. I personally could describe 10 ways to reduce the shoulder. I don't use 10 ways. I start with Ferres. I try Spazo. If I've got time, I'll lie them on their tummy and use Stimpsons. I think I've pronounced that correctly. With scapular rotation. And I will not try any traction, counter-traction techniques because they require either full anesthetizing of the shoulder joint, so in other words, local injection into the shoulder, which probably should be done under ultrasound guidance, or conscious sedation, which requires end-tidal CO2 constant monitoring to doctors and nurse and monitoring for an hour afterwards. So I try to use techniques that don't require conscious sedation. But I would say that 20% of the time you probably won't get the shoulder back in without conscious sedation or intra-articular anesthetic.
And that's usually a refer on in most cases. You would, in order to, particularly in smaller places, you can't do the conscious sedation safely, can you, if you to follow those guidelines? And
there's also the auto reduction technique, whose name escapes me, where the patient encases or grips their hands on the knee on the ipsilateral side and then arches their neck backwards to aid the reduction of the shoulder joint. So they can do it themselves. And in the emergency department, they've changed the name of it and they just tape the hands together.
I've had one orthopaedic surgeon tell me to lie the patient on their front, let the arm dangle with them holding a weight, and then just leave it there with that constant.
That's Stimpsons.
And go and leave the room and come back.
An excellent way of treating the patient.
Right. So there's lots of, I guess I chose Cunningham because it had that nice video, but there are lots of gentle atraumatic techniques, and finding one that works for you is probably the best. Personally, I do the prone scapular technique. I have the most success with that one anyway. But,
the challenge is that we learn how to do these techniques or shoulder reduction techniques in a hospital where conscious sedation is available, not in an urgent care setting. So ideally we should be able to train these techniques with enough people, personnel and equipment without having to use adjunctive drugs and get good at doing it. And I certainly know of doctors that are excellent with the Cunningham technique, but I still don't get it.
No. And it is relaxation at the end of the day. I was involved with trying to put a shoulder back in a very large rugby league player, and it involved an ED consultant, ED registrar, ortho registrar, lots of counter-traction, lots of drugs. And when the decision was made that he was going to theatre and the pulling stopped, he then fell asleep. And it was the sister who went over to the bed to just readjust him on the cot side that popped the shoulder back in when the guy was snoring. And we had to phone the ortho reg and say, sorry, you're not needed anymore. Sister got it back in when he was asleep. But the pulling was enough pain to cause him to not be relaxed enough. And he was just big and strong, and we were never going to win that war. So, that relaxation is part of it, isn't it? The other bite that I talked to you about the other week was that Google Translate, those two medical protection agencies in the UK saying that they didn't think it was necessarily a safe thing. What is the options for you in your clinic for translation? Do you have any? Have you ever used one of these telephone services, or are they even available?
It's an exceptionally challenging problem because in order to use the phone translation service, you need to have an account. And in order to have an account, the patient must be a resident, or your clinic must be willing to have an account, and the costs are quite extensive. So a non-resident who presents requiring a translation service, there are no options that I am aware of that I can use where I work. And so it's very difficult. So we have one side of the argument saying that, this is not safe. We have the other side of the argument saying there are no options. And so I don't have any easy answers. Using people who happen to be around who speak that language, or having staff who speak the language, is the best. But there are issues, so it's a real challenge, and I think we'd need to explore this further, because I'm not quite sure what the right answer is.
Yeah, and I think reading their bit, it did refer to, well, in an emergency, it may be the best option. And so I guess if you can say, look, there are no other options, then that's the Google Translate app. I used it actually for the introduction to the bite. I played it through a speaker through the app, and it got it exactly right when I showed it to the guy who had done the who'd said the words. So it is a very clever bit of technology, and it does seem better than nothing, or better than hand signals and talking loudly. So yeah, I think it's probably still a valid option for us at this stage, particularly because, like you say, if it's going to cost hundreds of dollars to get a translator, who then pays that? Is it?
I've had some very interesting translation cases. Obviously, an important thing is never assume. So I had a patient who I was trying to figure out whether they had tetanus, and I was sure they'd probably had tetanus vaccinations. But when he rang his parents in China, they said no, that he wasn't immunized, I found that very, very interesting and very helpful. And the other thing is, when your patients say they're not on any medications, and then they turn out to be on a massive big list of medications, and often you have to use Google search to work out these drugs, because we don't have all of them in New Zealand, and it's extremely frustrating to even find out what the drug is and what the doses are and what the contraindications are. So computers are very important. Translation is just one of the tools that they provide, and sometimes you have to work with what you've got. And I think probably documenting how you can.
Yeah, I was going to say, it's important to write it in the note, who was there, who translated, what services you used, and even things like patient.info can translate their information sheets into using Google Translate, but you're trusting them to be accurate when you're handing them over, because you can review the information in English and go, that's what subungual hematomas are, but then if you're entrusting the computer to translate it, it may not be completely right. So there's always that element of risk, isn't there? But it's got to be better than nothing.
And even professional translators. So I was watching Netflix, and it was a Danish program, and I could clearly hear some of the words that were being said, and then the translation was frankly ludicrous at times, and certainly my wife, when she sees Dutch translations, sometimes it's really worth a laugh. So translation is the quality is dependent on the translator as well, and even professional ones can come up with some interesting things sometimes.
So I guess be careful and document everything is probably the key take home at this point. What we'll do this month is we'll skip the news. There wasn't a huge amount of useful news items anyway, and I think we've covered a fair bit today already. So I think if we draw it to a close here, Dave, thanks again for your time and clarifying all these things. And just the focus of this podcast is for urgent care to be the main focus. And so we take things like gout and talk to somebody who's knowledgeable in gout, but then we've got to apply an urgent care lens to it. So having you to do that is always great. I would like to ask people to try and contribute their thoughts and suggestions. The podcast email is is there for that. And also, whenever the podcast goes up on Facebook, that's a place people can leave comments or things, because hearing what goes on out there in the world is useful, so that we can have this greater debate. You know, who uses this technique for this shoulder, or who's had this issue before. So yeah, I'd encourage people to try and interact a little bit more with the podcast, so that we can find out what's going on out there. And again, if you have something you want us to discuss or to look into, then suggestions would be good. And if anybody wants to talk on the podcast, that'd be great, because Dave's very kind and in appearing every month. But happy to try and hook up with anybody if they've got words to say. So, yeah, thanks, Dave, for your time, and we might see you again next month.
No problems. Thanks for having me.
Okay, thanks for listening. The information discussed in this podcast was intended for the ongoing professional development of qualified health professionals and should not be used for self-diagnosis. For any personal medical concerns, please consult your usual doctor.